Good evening and welcome to this evening's MDU webinar, the latest in our series, which tonight is on prescribing and avoiding prescribing errors. My name is Farnan. I'm one of the medical legal advisors here at the MDU, and I'm joined tonight by my colleagues Sarah Jarvis and Lennard, also medical legal advisors. I'm going to be giving a presentation which should last for about half an hour or so, and then while I'm doing that, Sarah and Nikki will be fielding questions in the background, and we will use those as the basis for a discussion at the end. It would be really helpful, because we're expecting upwards of 1,000 people tonight, if you could get your questions in early and try and keep them as brief as possible so we can identify themes. I suspect we might not be able to answer all of them because of the numbers, but if you keep them brief, get them in early, we can pick out common themes and try and cover as many areas as possible. Just a couple of housekeeping points. There will be a certificate sent probably within about 24 hours of the conclusion of the webinar, and then a recording of this will be available on our website within about a week, and you'll also be sent an email with a copy of that. There also will be a questionnaire. If you can hold on when the webinar concludes, there'll be a very short questionnaire, and then also some feedback questionnaire will be sent out to you afterwards. It's really helpful. If you can respond to that, it sort of informs what we will do next and our future planning, if you can give us a little bit of feedback once we've concluded. So in terms of this evening, beg your pardon, tonight's aims and objectives really just to analyse common themes across medication errors, why they might happen, what we can do to prevent them, some of the pitfalls that might exist, and also really just to review some of the GMC's prescribing guidance, because that allows us to focus on particular themes which cause doctors concern when they're facing these types of issues. Was it sensible to start by saying, what is prescribing? The GMC's guidance was published a couple of years ago, and while some of it is particularly relevant to prescription-only medications, which is what we tend to think of as being prescribing, it's important to bear in mind that the GMC's definition is much wider than that, and therefore the guidance should be followed really in relation to other activities which might be deemed to represent prescribing, everything from signing a prescription for a prescription-only medicine right the way to the provision of written advice and information to patients.
And I think we're starting to see your slides. I'm so sorry to interrupt.
Yep. Is there something in the way, or is there a technical problem? Is that any better, Sarah?
No, we can see your face, Ed.
Let me try that again.
Perfect. Sorry to interrupt. We can see it now. Thank you.
Lovely. So, yes. So yeah, as I say, there's a fairly wide definition of prescribing, which the GMC includes in its guidance. And then there's also a fairly wide definition of what might constitute a medication error. So this can sort of relate to things like prescribing, but also the preparing, dispensing, administering of medicines, or simply providing advice where something has gone wrong. And I think the fact that there are such wide definitions highlights that really it's a complex area of medical practice, and it's more than just the actual signing of a prescription. Well, why do we look at medication errors? Well, every year there's in excess of 1 billion items prescribed in England alone, with a further 100 million or so in Scotland, 80 million in Wales. And even if almost all of these are prescribed entirely correctly in terms of the content of the prescription, the clinical indication, the dose, the dispensing, the administration, only a tiny proportion need to go wrong at some level for the overall volume of errors to be high. So it's important to look at those, because we can learn from these for future practice. If you do become aware of a prescribing incident, it's important not only that you'll address any clinical issues which arise immediately with the patient, but also that you report the incidents. You'll have local clinical governance procedures which you should follow, and there may be other requirements such as the yellow card scheme. Those requirements locally vary from jurisdiction to jurisdiction across the UK. The GMC's prescribing guidance does contain some advice about how things should be addressed in terms of reporting requirements in each jurisdiction. So it's worth having a look at that if you're not sure. And this just highlights that even though the overall number as a percentage of prescriptions which go wrong in some way is low, the volume is perhaps high, and the ones we know about perhaps only represent the tip of the iceberg. Not every error will cause harm or even be noticed, but there's always the potential for harm. And in a small number of cases, the harm will be significant, may even cause death. I think most doctors are fairly familiar with the Swiss cheese model. And prescribing has many stages, and there may be an error at any one of these. And this slide, it's a slight variation on the usual Swiss cheese model, in that the usual model that you might be familiar with shows that all the holes have to line up and for something to go wrong at each point for an adverse incident to occur. This diagram slightly reverses that and shows that all the holes have to line up and for a number of different things to go right and in sequence for a safe prescription from the patient's perspective. Errors can be costly, and these are some figures from NHS resolution over a 5-year period, in which time there were over 1,400 claims related specifically to medication errors. About a third of these were settled at a cost of £35 million plus costs. A third were deemed to be without merit, but the other third at the time that the figures were published were still open. So the figure here given in terms of costs could significantly increase. And of those cases, about 2/3 related to a single error in one part of the process. So going back to that Swiss cheese model, all it takes is for one thing to go wrong, and it can cause a significant problem. 45% of those related to administration errors, about a third to prescribing, and about 10% to monitoring. This list of common prescribing errors is taken from our own files, MDU files. Obviously, prescribing a drug to a patient with a known allergy is a problem, and within that category, penicillin is probably the most common one that we see. Patients can't always, or sometimes don't, simply give a reliable history of their drug allergies. So it's important to record in the notes that you've asked about this, and then also what you've been told. So if there is a problem further down the line, that puts you in a strong position to say what you did and why. In terms of the wrong drug, it's important to take care of things like drop-down menus. Penicillin, again, it can be a problem. It looks very like penicillamine if you're in a drop-down menu and if you're in a rush, and obviously that's a problem. In terms of the wrong dose, all you need to think about is different strengths of opioids, which might appear on a prescribing system. Oromorph, for example, can be 10 milligrams per 5 mils or 20 milligrams per mil. And there can also be different preparations of the same drug. Some drugs should be administered weekly, but it's easy to erroneously type daily, simply out of habit. And in terms of interactions, side effects, contraindications, for example, think about a patient on anti-epileptic medications who unexpectedly becomes pregnant. In addition to that, some drugs require monitoring. It's possible if the right systems are not in place for those things to slip through the net. One of the things that the MDU can help with is if doctors are involved in an adverse incident, and we can review statements, we can prepare doctors for investigatory interviews, and these types of cases can escalate from an initial adverse incident, so it can be helpful for us to be involved at the outset. And we reviewed a series of calls to our medico-legal helpline regarding adverse incidents, and these calls often occur fairly early in the process before things have evolved into a complaint or a claim, for example. Out of 160 adverse incidents that we recorded over the period, medication errors were responsible for over a quarter, which again just illustrates how common an issue this is. Prescribing or administering drugs, medication, it's something that doctors do a lot of, so it's maybe not surprising that things go wrong occasionally. Of the sort of 160 cases, 28 related to a wrong drug being prescribed or administered, and of those 12 were vaccines. 5 were the wrong dose prescribed or administered, and a couple were things like out-of-date drugs being administered. In terms of the commonly involved drugs, well, maybe it's not surprising that the list of drugs which I've got here represents some of the more commonly involved incidents, because they're drugs which are very commonly prescribed. I think most people attending will prescribe one or more of these groups of drugs probably on a daily basis. But there are also drugs which are very well known to have significant side effects, even, I have to say, even when they're used appropriately or have other well-recognized problems, such as the potential to cause addiction or misuse. So they can result in problems for doctors, even if they're used appropriately, because they can cause adverse incidents. One of the things we often see, both in terms of adverse incidents, but also in other cases such as complaints and the like, is that communication problems can be a common theme. And if you're trying to manage a patient without access to their records, or let's say, for example, you've got the wrong records open in front of you, that's going to cause problems. Imagine, if you're running, for example, a vaccination clinic in primary care, and you've got the previous patient's records open, then you can all too easily end up giving the wrong vaccine. Communication between teams is also a really risky area for patients. It's that transition between primary care and secondary care on admission or on discharge, or a transition between one or more teams within secondary care. Those communication issues at that handover period, if those go wrong, that can cause a significant problem in terms of medication errors and adverse incidents. You might have two patients on the same ward, or two patients in primary care who are in the same household who've got similar names. Again, increases the risk of error. And obviously, transcription of information between different systems or scanning something onto a record, there's the potential for that to go wrong. So if I have a case example here, a patient seen it, in this case, it's described as cardiology outpatients, could be anywhere, could be primary care, secondary care. The patient's reviewed following an MI. The doctor who saw them noticed that they had elevated blood pressure, but also that they weren't on an ACE inhibitor, which might otherwise be indicated. They asked the patient about their other prescribed medication, and there were no apparent medication interactions or problems with what the patient was already taking. But they didn't mention that they were taking over-the-counter ibuprofen for back pain. The doctor advised an ACE inhibitor, and also about, in general terms, what to do if they experience side effects, cough, for example. 2 months later, they fell ill with a gastroenteritis, but continued to take the ACE inhibitor and the brufen. They became unwell, were found to have an acute kidney injury, and they sustained irreversible kidney damage. So what went wrong? Well, the doctor didn't ask her if they were taking over-the-counter medications as well as the things that they were being prescribed. And therefore, the regular use of non-steroidals didn't get taken into consideration. And the GMC's prescribing guidance, which we'll come on to in a bit more detail later, says that doctors should encourage patients to be open with them about their use of other drugs other than things that are prescribed, alternative remedies, over-the-counter remedies, illegal substances, online medications that they might be obtaining, as well as their previous compliance. So it would be important, to think what advice was the patient given, what was recorded in the notes, could anything have been done to prevent this? So the trust in this case is going to have to hold a patient safety investigation and to see what learning points might be identified. And this type of case, just to mention this in passing, may well also engage the statutory or the professional or ethical duty of candor for the doctor individually or for the trust as an organisation. It's not the time maybe to go into that in any detail. I'd flag up at this stage that we are running a course on duty of candor in a couple of weeks. If you're interested in that, there's information on the courses section of our website. It's also worth mentioning that this was a single clinical incident and it's resulted in an adverse incident. But that could sort of spiral into a number of other different processes: a claim by the patient, a complaint by the patient, disciplinary investigation into the doctor, a GMC investigation if anybody makes referral. All of these things can spin off from a single clinical incident. And again, what I would say is that if you find yourself having to deal with anything of this nature, please give us a call. We're very well placed to assist our members with any or indeed all of these. So what should you do if a prescribing error is identified? Well, you should report it using the internal reporting systems that you have in your organisation, Datix or similar. You should be open and honest with the patient and tell them as much as you can at the time. They say your ethical or duty of candor may be engaged, as well as the trust's statutory duty being engaged. When there is an investigation, that should be detailed and it should specifically identify learning points, if possible, and an action plan that should explain how procedures or practice will change in future if that's appropriate. And it's important to share that learning. I said we would be talking about some GMC guidance because it brings some themes together. This was published in April of 2021. It updated the previous version. And we're going to look at some specific areas, but just to highlight at the start some relevant paragraphs from the GMC's core ethical guidance, their good medical practice publication, which essentially says that it may well go without saying, but I think it's worth saying that you must recognise and work within the limits of your competence. But if you're providing clinical care, including prescribing drugs, you should only do so when you've got adequate knowledge of the patient's health and satisfied that the patient's needs will be met by that and that it's got an evidence base, and that it's compatible with other things that are being prescribed. Again, it should probably go without saying, but worth emphasising that doctors are responsible for the prescriptions that you sign. The GMC does encourage you to make use of other systems, for example, the BNF, any electronic systems, prescribing systems, safety alerts that might pop up there, the Medicines Compendium, MHRA drug safety updates, NICE guidance, all these resources are available, and the GMC encourages that you make use of those. Practically, on a day-to-day basis, senior colleagues within your team, pharmacists, clinical pharmacologists can also provide helpful support and advice. One thing which the GMC does encourage is to consider including on a prescription the clinical indication. Now, that might be slightly time-consuming when you do it, but it's one of these situations where stitching time may well save 9, because in practical terms, if a pharmacist sees what drug has been prescribed, but also if it says on the prescription what indication that was for, it might help them to understand the purpose of the prescription, which means they might be more likely to spot an error if the wrong drug has been chosen inadvertently from a pick list or a drop-down menu. So it's worth considering, although as I say, I appreciate that in practical terms, there may be a time element to that. The GMC strongly encourages dialogue with patients, for example, as part of the consent process. And this is very strongly emphasized in their separate consent guidance. But in the context of prescribing, the dialogue that you'll have before you prescribe helps to ensure that the patient understands what drug is being proposed and why, what the risks and benefits are, what the risks and benefits specific to the dose are in some cases, and what the benefits are if it's taken for the suggested time period. And again, according to their individual circumstances, that sort of dialogue and that conversation, as with any consent conversation, should be tailored to the particular patient where possible. And it's important, again, to take a proper history from the patient, including information about allergies, about non-prescription medications, and to try and encourage them to be open about any illegal drug use, because that may well inform your prescribing decisions. So that's a quick run through some of the general pointers from the GMC, really looking at sort of medico-legal hot topics and the things that we get asked about on a fairly frequent basis. The first of those is shared care. And most of you, I suspect, will be familiar with the concept of shared care, which is drugs which are more specialist, which would not normally be prescribed in primary care, and which require some degree of specialist knowledge or monitoring. But a shared care agreement will allow the specialist to recommend that a particular drug is prescribed and to advise the GP on the monitoring. And a specialist delegating this to the GP means that prescribing and monitoring can be done by the GP, which is generally convenient for the patient. But a shared care protocol should usually include advice to the GP about what or when they should contact the consultant, for example, if routine monitoring bloods start to become abnormal. Again, you are responsible for the prescriptions that you sign, and it's important, therefore, that there's a mutual three-way agreement between the GP, the specialist, and the patient. The person signing the prescription must be consent to do so, and the person making the recommendation has a responsibility to satisfy themselves with this. And the discussion about whether a shared care agreement is appropriate is likely to be particularly relevant if it's a new or a rarely prescribed medication. Shared care is fairly common in some specialties, such as rheumatology for disease-modifying drugs, less common in other situations, and a more robust discussion an agreement between all parties might be more important in those cases. So in other words, if you're the secondary care doctor, and if you're asking a GP to participate in a shared care agreement, there are things which you will want to do to satisfy yourself that it's appropriate and that the GP is confident to proceed in a way which is safe for you as the person making the recommendation, for them as the person who's going to be writing the prescription, but most importantly, for the patient whose needs are paramount. Similarly, if you're the GP and if you're not sure, then you shouldn't really proceed until you've sought further information or advice from another colleague or from the clinician who's making the recommendation, and it may well not be appropriate to proceed until such time as you are satisfied, assuming that's the case. If that is the case, and if it's felt that you're not happy to proceed, then really what's important in those situations is to focus on the patient's requirements, and between you and the secondary care clinician and others if necessary, you make sure that alternative arrangements are in place so that the patient is not disadvantaged, even if you're not in a position to facilitate the shared care prescribing. So as I say, it should be agreed between all parties. There's some information which should be given as part of that process, and there may well be local arrangements in place. There's things like a traffic light arrangement, for example, in some areas whereby red drugs are specialist only, amber drugs are suitable for shared care, and green drugs can be prescribed pretty much by anyone. That's a quick run through shared care. As I say, it's a topic which we are frequently asked about. If you have specific questions relating that at the minute, stick them in the question box. We'll try and sort of come to those at the end. Otherwise, we're always happy to take a call on the advice line or drop us an email if there are particular concerns that you have. Another hot topic, so to speak, is the use of unlicensed medicines. And just to quote specifically from the GMC guidance, they say that an unlicensed medicine is a term used to describe medicines that are used outside of the terms of their UK license or for which they have no UK license. They're commonly used in some areas like peds, like psychiatry and palliative care, but they're also used, albeit less frequently, in other areas of medicine. What is important is that you should usually prescribe licensed medicines in accordance with the terms of their license, but you may prescribe unlicensed medicines where, in an individual case, and for good medical reasons, you've decided that that's necessary to meet the specific needs of the patient. In that case, if you are going to prescribe an unlicensed medicine, then you have to ensure that there's enough evidence that the medicine is safe and efficacious. You have to take responsibility for the prescribing and, if necessary, the monitoring of that. And you should make an accurate record if you're not following common practice, for example, if you're prescribing off license. As part of that consent and the dialogue process that I talked about earlier, you do need to give patients enough information so that they can make an informed decision about the proposal. Some medicines are perfectly routinely used outside the terms of their license, and pediatrics is a very good example of that. In other cases, such as in emergencies or where there's no realistic alternative treatment, and if it's likely to cause distress, it may not be possible or practical or even necessary to draw attention to the license. In some cases, prescribing unlicensed medication may be supported by good guidance, in which cases it may be enough to discuss that in fairly general terms, why the license is, or why the medicine's not licensed, and why you're proposing to use it. But you should be prepared to answer questions from patients or their parents or their carers, honestly, if you're explaining to them why you're going down that route. Conversely, if a medicine, unlicensed prescribing of a medicine is not routine, or if there are suitably licensed alternatives available, you will need to explain that in much more detail to the patient and give very specific reasons as to why an unlicensed medicine is being proposed. An increasingly hot topic over the last couple of years, for obvious reasons, has been remote prescribing. And the GMC's 2021 guidance, which was sort of published midway through the pandemic, significantly increased the amount of information and guidance relevant to less traditional formats of consultation. And COVID, has meant that many more consultations are taking place by telephone, by video, or by remote means. And I suspect that's going to continue to be the case. I don't think we're going to go back to the way we were before. What's important is if you are consulting remotely and if you are prescribing based on a remote consultation, you must ensure that you're still in a position to prescribe safely, irrespective of the mode and the means of consultation. So in other words, you need, as the prescriber, to be satisfied that you can make an adequate assessment of the patient. You can establish that dialogue that we talked about, so to obtain consent using the particular mode of consultation that you've chosen. And if you are consulting remotely with a patient, we certainly would suggest that you keep an open mind about these types of issues throughout the consultation. And if you're not happy to proceed with the prescribing or with the consultation, whether that be by phone, by video, by online means, because you think it's not safe, then consider reverting to a more traditional consultation, face-to-face if necessary, if you think that you can't continue safely for any reason. A couple of specific points here, and the first point really applies to prescribing in any context, whether it's remote or otherwise, but it's perhaps worth emphasizing in the context of remote consultations, and say that reversion to a face-to-face consultation may well be appropriate and safer if, for example, you're not sure about a patient's capacity, or if you physically need to examine them in a way that you can't do remotely, or if you're not the patient's usual doctor and don't have that rapport or previous knowledge, or if you've got safeguarding or similar concerns or concerns about coercion, which you may pick up soft markers online or by video, but you'll be able to sort of reassure yourself, I think, in a more traditional consultation. Second point, I think, is it's not new. It's guidance which existed in the GMC's previous advice, but it's worth sort of teasing it out here because we are consulting remotely more than we used to. Patients are used to it, doctors are used to it, but the point is that if you are going down the route of non-surgical cosmetics, the sort of the Botox, the fillers, you can't do that remotely by phone, by video, or online. That does need a face-to-face consultation. And again, the first point is specifically required by the GMC if you're not the patient's usual prescriber, but it's probably good practice in any case if you're using a medium which you or the patient is less familiar with. Just say who you are, what your role is, and so on. It's part of that sort of virtual handshake at the start of a consultation. And the other points there are also applicable in any setting, including a traditional consultation, but they're worth taking particular care of, bearing in mind the limitations of the medium that you're using. Because you're physically not in the same room as the patient, you will not get sort of the non-verbal cues. The consultation may be more limited, so it's important to show that you've allowed for that, you've taken steps to address it and overcome any limitations, and that you document how you've done that. A specific thing which came up in the more recent GMC guidance, and it addresses one of the particular challenges of remote consultation, is the fact that you might not actually know where the patient is. So the GMC added this to their guidance in recognition of that. So if you are prescribing for a patient overseas, you will need to consider whether you are indemnified for that. You will need to consider whether the regulator in that country would require you to be registered there, because that's where the patient is. And then there are practical differences about how the patient will be monitored. What are the manufacturing differences which might exist? You need to take all of those things into consideration. The law varies from country to country, so it's not possible to sort of answer specific jurisdictional queries about whether one country would accept things and another country might not. Suffice it to say that if a doctor is found to have prescribed contrary to another country's laws, not only will they face possible sanction in that country, but the GMC may investigate them as well. And in addition to those points, if you are in a position to prescribe remotely for a patient overseas, having taken all of those points into consideration, bear in mind that there may also be relevant import and export laws which need to be considered. So in other words, if you are prescribing remotely, thinking about the limitations of the medium, whether an examination's indicated, whether you have the records and so on, it's worth having those questions certainly at the back of your mind, and perhaps even at the front of your mind. That might help to ensure that you don't stray too far from the guidance and from best practice. Another quick scenario, situation where a doctor had seen his own GP with back pain and was prescribed a non-steroidal. A few weeks later, back pain got a bit better, then got worse again. He was about to head off on holiday. He didn't have time to go back to his GP. He was working back-to-back sort of night shifts. So he wrote a private prescription for himself for some more diclofenac, and also threw in some diazepam just to help him sleep after a series of nights and a long flight, where he thought, muscle relaxant might not do any harm. Pharmacist saw the prescription, dispensed the medication. Doctor thought nothing more of it. But after that, the pharmacist referred the doctor to the GMC, and I have to say this is something we do see not infrequently. And the GMC wrote to the doctor advising him that they were opening an investigation into his fitness to practice. And the doctor at that stage contacted us. So what were the GMC's concerns, I suppose, is the obvious question. Well, the GMC is very clear that wherever possible, you should avoid prescribing for yourself or anyone you have a close personal relationship with. And if you do go down that route, you should make a very clear record of it at the time, and the reason why it was necessary for you to prescribe. And you should follow advice on information sharing and safe prescribing. And it's, for example, sharing information with the patient's GP or with the doctor's GP if you're the doctor who has prescribed. Diazepam, of course, is a controlled drug, and there's very specific and more stringent guidance about that from the GMC. And the reason we're essentially including this is that it's a brief reminder that having a license to practice brings with it the permission to carry out certain activities, one of which is prescribing prescription-only medicine. But the GMC describes these activities as privileges. And doctors who exercise those privileges for their own convenience may well find themselves subject to criticism. The good news in this case, well, with some input from his medico-legal advisor, the doctor went back and reviewed that guidance, which I've just showed you. They reflected on the concern raised. The MDU was able to assist with a response to the GMC, explaining and emphasising that this was a single incident. The doctor hadn't given proper consideration to the guidance, but having reflected on that, certainly would not find themselves doing the same thing again. And the GMC was reassured by that and was in a position to close the case with a letter of advice. So really, in summary then, this has come up a couple of times in the slides. Recognize your own competence and experience and prescribe within the limits of that. Make sure you're familiar with the drug. Make sure you're familiar with the patient. Work with others, consult with others. There's a team working around you. Rely on their advice. There are particular requirements in terms of remote prescribing, which I've highlighted. And the one point which isn't there is keep good records. It will get you out of a lot of trouble if there is an incident later on down the line, if you can show that you took reasonable and appropriate steps to make sure that you were prescribing as safely as you possibly could. Just a reminder, in case you joined us late, there will be a certificate sent out within about a day or so. Before the webinar finishes or just after we finish, there will be the opportunity to give us a couple of very quick pieces of feedback. We'd be very grateful if you could stay online just until that comes through. There will be a further feedback questionnaire as I understand it, so if you can give us as much feedback as you can, it really helps us in terms of planning. A recording of the webinar will be available to the website over the next week or so, and I believe you will also get a link to that sent out to you by email. So having had a whistle-stop tour through prescribing, Sarah and Nikki hopefully have been able to field some questions in the background.
I think we have, and I've been looking, and we've got a few, I guess, themes. One of which is about prescribing for patients who are going abroad. So at the point that the prescription is issued, the patient is in the UK and the doctor is in the UK. My experience is that there are some medications which may be illegal to import to other countries, so patients may need to take their own advice about what is appropriate and what is safe, because every country will have different import regulations. But if you are seeing a patient within the UK and providing treatment in the UK, it is the UK legislation and regulatory framework that would apply there. I don't know if you've got any comments, Ed or Nikki, about that.
No, I don't think I've got much to add other than, you know, provided the patient is in the country at the time when you assess them. And there was a question that was similar about issuing rescue meds for COPD for someone to go abroad on holiday. And I think that would be an entirely reasonable thing to do because they have a very genuine reason to take with them. Clearly, some individuals go abroad for much longer periods of times, which would require a much bigger supply. And that can cause issues as well, particularly if there are, I suppose, controlled medications within there, and there would be particular rules that apply to that.
Yeah, the only thing I would add to that is if somebody is going away for a short period or a long period and you're giving them medication, is that you make sure that they know what they need to do and what signs and symptoms to watch for in terms of side effects, like that patient with COPD. It may be reasonable to give them that rescue medication, but they also need to know when to seek help locally when they arrive with them.
Thank you.
Yeah, there was an interesting question with regards to the GMC guidance on self-prescribing, which was why don't they just make it a definite no, that not a sort of grey area. I think they're fairly clear on their guidance in that it is almost as much as a definite no as it can be, apart from in extreme circumstances, and certainly that's my sort of understanding of the guidance. But let me know if you think there's any difference in relation to that.
I think somebody also commented whether it should be made illegal, and of course GMC is a regulator, so it provides regulatory guidance for those who are on the register. The GMC doesn't make the law, but of course doctors who are prescribing still have to work within the legal framework that is there. So I think our advice is that really self-prescribing can get you into all sorts of difficulty, and it's really not something that you should
Yeah. Another interesting question, which I will ask to both of you two as former GPs, really, in that if a patient is taking a medication that requires regular monitoring and they're refusing to comply with your request for monitoring, how do you deal with that? And at what point do you say, I'm not going to prescribe that for you?
I think it's a generic question which I think needs a patient-specific answer. There will be drugs which need to be monitored in an ideal world, or conditions which need to be monitored, and it would be unwise and unsafe to stop the medication for those patients. I'm thinking something like insulin for a type 1 diabetic. The risk of stopping that medication would outweigh the benefit in that case. The flip side would be something like methotrexate for inflammatory arthritis, which clearly requires significant monitoring. The risk of going unmonitored on that is probably outweighs the risk of continuing to prescribe. So I think you need to judge it on a case-by-case and on a drug-by-drug basis, but be prepared to justify the decision. Again, it's one of those things where if doctors find themselves in that situation, it's probably sensible to have a very clear discussion with the patient, document it, follow it up in writing, send a letter by record delivery explaining the risks, and if they're still having problems, by all means contact us. We're very happy to talk through any medico-legal issues that might arise.
Yeah, I would echo all of what Ed has just said there then, and often this is a clinical decision about the risks and benefits of continuing the medication versus stopping the medication. Sometimes it could be really helpful to have a second opinion from somebody with specialist knowledge regarding the risks and so on, but often it is a case of trying to explain to the patient, documenting that discussion that you've been having. With many of these things, as you can imagine, as a medical defence organisation, we would urge that you document these discussions, and that you try and engage in what is often a very difficult dialogue with the patients about why the monitoring is required and so on there then. But absolutely, it is a case-by-case matter, and we're always happy to advise MDU members who are facing that very difficult decision.
Yeah. Looking at another sort of set of questions that have come in that really apply to shared care agreements and sometimes prescribing unlicensed drugs as well, often shared care agreements about unlicensed drugs as well, which can be quite difficult. And I know that this is an area that causes a lot of concerns. There was a question as to whether or not you have to agree to a shared care agreement. And I think the GMC guidance is reasonably clear that you don't have to agree, and you have to make sure that you've got all of the right information available to you to be able to prescribe that medication safely and to understand the monitoring that is required. So, you know, there is a duty on the hospital doctors or the secondary care doctors to provide sufficient information to allow an individual, a GP, to take over a shared care agreement. And if you as an individual do not feel you've got sufficient information, you should keep asking for more information, but not prescribe until you feel it's safe to do so.
I think that's very sensible advice, that when you're signing the prescription, you are taking responsibility, and you need to follow all of the GMC guidance that is there. Had another interesting question early on as to whether recommending an over-the-counter medication would be regarded as prescribing. And the GMC's guidance makes very clear that the guidance in that does apply to recommendations and to advice, as well as the issuing of prescriptions. So I think that's something to bear in mind. I know that sometimes doctors may be under pressure from patients who don't want to pay perhaps a prescription charge, whether there's anything that they can buy over the counter. You would need to take the same care in making a recommendation for an over-the-counter medication as you would if you were going to issue a prescription. And I think there was another question about the role of pharmacists in prescribing errors, and I wondered, Ed and Nikki, if you had any views on that.
Certainly, I think it's helpful to involve as many people as you can in the safety net of prescribing. Pharmacists, both within the community and within the secondary care setting, are a vital role in that. But in order to be able to I suppose, deliver their role adequately, it is helpful if they have some information about why a drug is being prescribed. I fully take on board that is not always possible, and there are time constraints to that. But I think there as much cooperation as possible, if possible, with pharmacists and allied healthcare professionals. We also need to remember that in hospitals and also, I suppose, care homes, you often have a nurse or another individual who's actually administering the drugs, and can also be a helpful ally in terms of the prescribing side of things.
Thank you. And we've had a series of questions also on patient information leaflets, which of course are included in packets of medication when they're dispensed, and whether that would count as sufficient information for giving to a patient. And that was asked as a generic question, but we've also had a separate question regarding remote prescribing in those circumstances. So if I could ask you, Ed.
I think they're a really helpful resource, but I don't think they can be relied on to the exclusion of all else. You're the prescriber. It's certainly perfectly reasonable as the prescriber, when you're having that dialogue that we talked about, to explain to the patient that there should be a patient information leaflet there, that they should read that in addition to the discussion that you've had, because hopefully they'll remember some of what you said. They may not remember all of it, so hopefully that patient information leaflet will reinforce that. But you have a responsibility to make sure that they have taken on board certainly the key points as part of that consent process. You can't simply rely on the hope that they will go away and read it. There are occasions, and I think we've all come across them, where for some reason, one reason or another, the patient information leaflet doesn't seem to have been in the box. And inevitably that will be the case where something goes wrong.
Yeah, I would agree that they're a really helpful addition to the information that you provide, but you also need to provide the information as well to the patient or their carer. There was a question relatively early on about what a GP should do, for instance, with an asthmatic patient who's requesting a non-steroidal for pain management and who is insisting that they don't get breathing problems with that, how they should manage that. don't know if anybody's got any advice in relation to that.
Yeah, again, we didn't sort of particularly pull that piece of guidance out from the GMC guidance, but the GMC is clear that if you are content and satisfied that the medication which is being requested is not in the patient's best interest or wouldn't satisfy their needs, then you're under no obligation to prescribe it. There will be, again, a conversation to be had in those situations. There will be perfectly reasonable and effective alternatives in most cases, but prescribing something which could harm the patient and which you know could harm the patient and simply taking on trust what they're saying, I think could leave you in a very vulnerable position.
Thank you. And I'm going to go back to the theme of being abroad. We've had a question whether it's okay to prescribe for a visiting cousin who's funding themselves privately and then wants to take the medication abroad. And I think this raises a number of questions. I think the first thing that I would say is that if the GMC guidance is clear that you should not treat those who are close to you in the same way that you should not self-prescribe. And I think that would be a concern, perhaps to employers, maybe to the GMC as well. But I think it also raises questions about indemnity, because in those circumstances you may be issuing a private prescription and you would need to make sure that you had cover in place to issue those private prescriptions. So that might be quite a relevant consideration for a doctor who's working in hospital, but our advice is that you should not be treating those who are close to you, and in fact the safest thing in those circumstances is to signpost to somebody who can do that. I think it also brings up the question about prescribing for those patients for whom you don't have full access to medical records. And I think that also is difficult sometimes, that you have to put yourself in a position that you've made an adequate assessment, and that can be difficult if you don't have access to records. I don't know, Nikki and Ed, if you had any other points to add to that.
Not so much from a prescribing perspective. The only thing to add in there really comes back to records, that if you've dealt with that cousin effectively as a patient, then you would be expected to keep proper medical records about your assessment in a way which was consistent with whatever your own policies are. And data protection legislation, and I think you're probably not going to be in a position to do that, and that's a further area where you could be criticised.
Yeah, I'd agree with that, Ed. There was a couple of questions, I suspect, from hospital doctors and about prescribing in a sort of MDT type setting, and prescribing, for instance, if there's a patient coming into hospital for a certain procedure, and a nurse prepping the patient comes up and asks you to prescribe a medication for that patient. Obviously, you've not necessarily seen the patient. Does that count as a remote consultation? And does the responsibility for prescribing still fall to you? Certainly my understanding of the situation is, if you are the one that is signing that prescription, then ultimately the responsibility for that prescription rests with you as an individual. And if you've got any concerns about what you're being asked to do, you need to find out more information about the patient, looking at their medical records, and if any specific concerns come out, then speaking with the patient themselves.
Yes, I would agree with that. And we've had a few questions, I guess, about the MDT, because of course most doctors now will work as part of a team, whether that's in primary or secondary care. And we did have one question as to whether, if a medication had been put on the repeat prescribing system, but had initially been prescribed in error, and then subsequent doctors follow behind and sign those repeat prescriptions, who is responsible in those circumstances? And I've certainly had files here at the MDU where there has been a complaint, and in some cases leading to a claim. And in fact, the actions of all of those doctors have been subject to review. And I think that's the thing to bear in mind. In the event of a complaint or a claim, then everybody's actions are likely to be scrutinised. And so it's important that you have systems in place. And I know certainly in general practice that over the years they've become the medication reviews have become a very important part of patient care, and they do offer an opportunity to sort of make sure that you go back and that you check that the indication for prescribing is still there, that the general health hasn't changed, you know, that if somebody's on a drug that can affect the kidneys, that the renal function hasn't gone off. So I think those are really, really important to make sure that you've got systems in place for making sure that medications are appropriate. And that can be really important. I know we recently had a webinar on opioids and coroner's cases and things, and making sure that you can justify prescriptions on an ongoing basis. And I take on board very much the comment from one of our GP colleagues who said it's really difficult in a 10-minute consultation with so many patients on lots of medications, and we absolutely hear you about that. So I think having the systems in place can sometimes help, that got policies and so on in place for prescribing and repeat prescribing in particular. And Nicola, I don't know if there's anything else you want to add.
No, I mean, I just empathise with the time constraints that doctors are working under, and it always feels like we're giving an endless list of jobs for you to do, and it's not how it's intended. We hope that the information that we provide is helpful and useful, but we do understand you're in a really difficult situation. There was an interesting question in relation to sexual health and communication with GPs, and sometimes patients not wanting their GPs to know about attendances maybe at sexual health clinics and sexually transmitted diseases. Ed, I was just wondering if you'd like to sort of respond to that query. Do you have to inform the GP about certain sexual health diseases and attendances at clinics?
My understanding is that sexual health clinics and the like are the exception to the rule in terms of what is advised. It's generally good practice for doctors in secondary care to liaise with their colleagues in primary care and to encourage patients to allow that. My understanding is that secondary care is regarded as slightly different in terms of sexual health. While that conversation may well still be encouraged in terms of informing the GP, a patient who doesn't want that information to be shared, their views will usually be respected in that situation. I think that's a policy decision, really, just to encourage patients who may have a sexually transmitted disease, which clearly has significant public health implications. It's to encourage them to feel confident that they will be able to see somebody confidentially, access the treatment that they need without having information shared back to their GP because they feel self-conscious, because for whatever reason. So I think while it's to be encouraged that they would allow information to be shared with their GP, it's not likely to affect their care, and it's not mandatory by any means.
Thank you. I think as well we've had quite an interesting point raised. What if a patient is not honest about over-the-counter medication that they are taking? Or indeed whether they may be obtaining supplies in particular of perhaps a controlled medication from elsewhere that they don't declare. And I appreciate that it's difficult, but I think you know, you have to ask the questions and you have to look at the patient in front of you and see whether the information fits with the clinical picture, and then make a decision as to whether it's appropriate for you to be prescribing those medications, or if it's simply better for somebody else to prescribe, so that there's no risk of duplicate prescribing and so on. Nikki, did you have any thoughts on that?
I would agree with that. I don't think there's anything else that I can usefully add, really. I think you've covered it all. Thanks.
And I think, you know, you can only ask the question, and if the patient chooses not to be honest and so on, then you can't be responsible for that patient's not being honest, but you would be responsible for your own clinical observations and judgments as to whether that's appropriate. I think that's the key thing.
You can only, you're only as good as the information that you've been given, and there has to be an element of trust between you and your patient for the doctor-patient relationship to continue. So if there's concerns that you don't believe the answers that you are being given, then obviously a second opinion might be helpful. But otherwise, generally, you believe what the patient tells you and you act on that information that's given to you.
And we've had some more questions about self-prescribing as well, whether if a GP or somebody else has started medication for a doctor, is that doctor okay to prescribe a small amount of medication if they're running out? And my advice is definitely not. I think this is probably the biggest take-home message in terms of keeping out of trouble from this seminar, is that really self-prescribing leads to all sorts of problems. So I think it's worth repeating that, because I think it's such an important piece of advice for keeping doctors out of trouble.
Someone has raised the interesting question about patients getting medicines from abroad, and those I can cause all sorts of difficulties, because we might not have any clear idea what is in that medication. It might not be something that is known in this country. I suppose it's like asking about over-the-counter treatments and sort of herbal and alternative remedies that people are taking, asking them if they are taking any other medication, particularly important, and asking them to provide information on that if they're able to.
I think it also that sort of brings up, I guess, the issue of inherited prescribing decisions. So perhaps when a patient comes from abroad for the medication that isn't familiar, or indeed if a patient transfers practice from another area, and the patient is on a medication that perhaps isn't on your local formulary, I think it's worth reminding people about the medicines management teams that are generally accessible to most teams working in primary and secondary care, to find a safe and effective alternative, perhaps to get advice on switching and so on there then. And again, I would advise that if that is the case, that it's documented very clearly, and that there's a discussion with the patient about the new medication and why that has been selected as well.
I think we've probably got time for one more, if you have one.
I am just
There was an interesting question about lost control medicines and what you should do when someone keeps losing their controlled medicines. That is something that crops up fairly frequently, and we do see questions in relation to that. Obviously, the concern is that those drugs are going elsewhere or are perhaps being overused by the individual themselves. And questions to explore that need to be asked, and ways to minimise potential harm to the individual themselves or others need to be considered. There was a question as to whether or not we should be referring those individuals to the counter fraud service, but there are all sorts of confidentiality questions that are raised with regards to that. So before anybody considers going down that route, I would recommend that they seek advice from their own defence organisation.
Absolutely.
I think that we all have we have to be very mindful of drugs with potential for abuse, and some of those are not necessarily opiates. But I think it's absolutely right that you have systems in place to deal with that, and that perhaps a discussion needs to be had with the patient, even sometimes signed behaviour agreements about what practice is able to do and what they're not able to do, and really whether the prescribing might need to have some specialist input and so on as well, that if there are drugs which have been prescribed for a legitimate clinical purpose and then they become a focus for abuse, then how that is dealt with, need to consider that very carefully as well.
I'm conscious that we're now at 8 o'clock. It's a lovely evening outside. Certainly it's a lovely evening outside here. Outside where you are, I'm sure you're keen to get out and enjoy it while it lasts. So I'd like to thank everybody for joining us this evening. Thanks to Nikki and Sarah and our team in the background fielding questions. I hope that it was useful. As I say, the recording will be available on our website. But for now, all it remains for me to do is to thank everybody for joining and wish you a very good evening.
Thank you.
Bye-bye.